We now have the great opportunity to hear directly from our colleague in Pakistan. Tazeen is going to talk with us about the WHO inventory process, and as a clinical engineer, she has been a leader in our field in this coronavirus effort. Welcome to the presentation.
Thank you so much, Elliot. Hi, this is Tazeen Bukhari. I'm a clinical engineer based in Pakistan who works as a consultant with various NGOs such as World Bank, DFID, USA, and other private and public organizations. Recently, I was hired as a consultant by WHO Pakistan to carry out to use the WHO inventory tool for public and private hospitals in COVID-19. The main task was to assess the baseline availability of biomedical equipment, including oxygen systems, and to identify the need for future procurement and trained workforce. Next slide, please. To start my presentation, I've just added this map of Pakistan to make you understand that we have 5 provinces: Punjab, Sindh, Balochistan, KPK, and AJK. Balochistan is the largest province, but Punjab is the most populous province. Hence, it gets the highest budget as well. Next slide. Next slide, please. The object was to create the baseline for biomedical equipment, to gauge the preparedness for COVID-19, and to define needs and make informed decisions. For procurement and relocation of resources for a second or third wave or any other respiratory disease. My task was to facilitate and validate data through liaison with WHO provincial office and the provincial focal persons that were present in the government. We also had to create a guideline for intervention required in terms of oxygen systems and biomedical equipment for infrastructure and human resource. And obviously quantify a national standard for selected biomedical equipment, so we know exactly what is the minimum number that should be present in a certain type of facility. So, to conduct the survey, the WHO regional office was involved in the country also. They liaison with the DG National Health Services Regulation and Coordination for facilitation of the survey. Focal persons were identified from the WHO offices in the provinces and also the government in all provinces, because we wanted to give them ownership of the data. Health facilities from each province was identified. They were mostly tertiary care hospital, district level hospital, and some of the private care facilities. Next slide. Since WHO Pakistan does not have a clinical engineering lead, and keeping that in view, and the expertise that was present in the healthcare facilities throughout Pakistan, we modified the survey. We included a few new equipment as well, and it was broken down into basic information, oxygen systems, medical equipment, and maintenance information. So what we did was, because if you've seen the survey, it would ask after every equipment, is it functional? What is the reason of non-functionality? Instead of doing it for every equipment, we did another separate section for maintenance information to identify what was the problem. A guidance document was also prepared, and we added pictures with the equipment, because there were a lot in the healthcare facilities that it was not necessarily a technical person was doing it, so they need to know exactly what equipment are we talking about. We covered everything what we could, but the main problem was that we did feel some issues. Mainly because health service delivery is a provincial subject in Pakistan. Provincial governments were very skeptical. We did contact the DG National Health Services, but the provincial government were like, we don't want to share the data because of politics, or the opposition would use it against us. It was and that would cause a lot of delays. A lot of persuasion was done, but getting a focal person on board and the overall process was difficult and resulted in delays. As identified earlier, I'm still on the last slide. As identified earlier, WHO Pakistan does not have a clinical engineering team or a lead, and various other teams had to be involved from the WHO Pakistan team. They were short on manpower. Manpower was a big issue, and we had to rely mostly on the government data that they had to provide. There were other unforeseen circumstances, such as there was a polio campaign going on or floods in one of the provinces, which also had resulted in delays. And like I mentioned, we did modify the survey to include all the health facilities and the technical persons over there, but still the information was incomplete. But we did manage to get a sizable amount of data. 32 hospitals were from Punjab, 10 from Sindh, 7 from Balochistan, 48 from KPK, and 7 from AGK. The key identifiers were PSAs and VIE. So yeah, the VIEs or PSAs were not installed. There were no medical gas pipeline. And you would see that there are similar kind of facilities. So there's a DHQ hospital in Punjab and there's a DHQ hospital in Balochistan. But the level of equipment they have is totally different. Punjab would have a lot of ventilators while Balochistan would not. And this disparity was not right. So the previous slide, that was the data representation. So what we did was we took all this data and presented it for every province, and then added that data and sort of made a country level presentation as well. So the main things were the basic info: how many beds, ICU beds, HTU beds, all of that. Then there were oxygen systems. Do you have a medical gas pipeline? How many cylinders do you use? Do you have a PSA? That was representative. The other thing was all the biomedical equipment, including vital signs monitor, ventilators, pulse oximeters. And since the data, survey was modified, we also had information about the number of CTs, the number of X-rays, the number of ultrasounds, PCR machines, chemistry analyzers, and things like that. From the non-functionality of the equipment was quite high throughout the provinces, except in Punjab, which had a better system than the rest of the provinces. If you can see on the slide, Punjab has the lowest, but Balochistan is close. The problem is those results were not right. When we talked to the people who were in the facility, they said that they did not know the whereabouts of the non-functional equipment. They did not fill in the data, and hence there was a disparity in the results. And the main problem that was identified was that there was no maintenance setup, and that needs to be addressed. So this is the summary slide. I have already talked about the unavailability of medical gas pipeline. There were issues with maintenance system, and there was disparity between the equipment availability. Can you move to national best practices now? I've already covered this. So once we had the data, we selected 5 national best practices. These were five hospitals: 2 from Punjab, 2 from Sindh, and 1 from KPK. 2 of them, Shaukat Khanum and Aga Khan, are JCI accredited, while others are good centers as well. We only selected 3 identifiers, which was critical bed to ventilator ratio, total bed to monitor ratio, and total bed to pulse oximeter ratio. And also calculated the national average from the data we had collected, and worked towards a recommended ratio that should be a rationale for the country or a certain level of health facility, where we are talking about tertiary facilities over here. The survey leads to a conclusion that we need to work on a national policy for biomedical equipment. And WHO Pakistan can help in this way by hiring a clinical engineering team or a clinical engineering lead who could help the government to implement these standards and norms for biomedical equipment. This includes management, maintenance, and regulation of biomedical equipment, including the oxygen systems. In terms of oxygen systems, medical gas pipeline should be installed in all the DHQs and THQs. I'm on the next slide. Should be installed in all the DHQs and THQs. PSA facilities should be available for far-fetched areas. and and production of oxygen should be increased. It should not stay with the provincial, with the private sectors, but provincial level and district level should also be involved in production. Conservation of oxygen, procurement based on demand and supply, and regular training personnel is also something that we need to work on, which is not there in most of the health facilities in Pakistan or on a government or provincial level. Next slide. For biomedical equipment, the biomedical maintenance management system is very important. Equipment to critical ratio on a similar type of facility or all provinces. Essential health facilities, there should be an inventory. We need to work on regulation with Drug Regulatory Authority of Pakistan. Biomedical engineering training setups should be done, master trainers should be there, and schools should be created. WHO and Ministry of Health can work together on a system and create a guideline for basic troubleshooting or maintenance setup and management, which should be important. There should be national advisory board to cover the risk and adverse effects of medical equipment, and Ministry of Health should collaborate with these national best practices and learn how they do it, so we can improve the overall public sector system in Pakistan. That's all from me today. Thank you so much.
Thank you, Tazeen, and thank you for your patience with our startup with the webinar and the delays in our system. Thank you for your work, steadfast work through the pandemic and leadership